Welcome to Empowered Voices, Recovery to Resiliency.
Yay.
I'm Dr. Farzad Kamyar, joined by my wonderful co-host, Miss Amani Wilson. In this episode, we're going to talk about the state of substance use with a focus on Southern Nevada, but also some trends we're seeing in Nevada and across the U.S. We'll discuss current patterns, emerging concerns, and local contexts that shape substance use in our communities. This foundational knowledge should help us sort of demystify statistics often cited in media and inform community responses.
And joining us today, we have two guests from the Southern Nevada Health District. First, we have Ms. Jessica Johnson, Health Education Supervisor at the Southern Nevada Health District. In her role, she has led impactful public health initiatives that resonate across Southern Nevada. As co-chair of the Southern Nevada Opioid Advisory Council, Jessica continues to champion critical public health initiatives that address substance use challenges in our region, with profound dedication to health education, prevention, and outreach. Also, we have Brandon DeLise, Senior Epidemiologist at the Southern Nevada Health District since 2018, where he leads efforts to monitor, develop, and improve surveillance within the fields of drug overdose and EMS. Prior to working as an epidemiologist, Brandon was a disease investigation and intervention specialist at the Southern Nevada Health District. Brandon also serves on the board of the Clark County Regional Opioid Task Force. Thank you both for being here, and welcome, welcome, welcome.
Thank you so much.
Thank
I'm so
you
glad to
for
be
having
here
us.
today.
Yes, happy to have you.
All right. Yeah. I appreciate you both being here. Thanks so much. Okay. So let's kind of jump into what's the current state of substance use in Southern Nevada, looking at like trends, substances, et cetera. But how about this? What are the most prevalent substances of concern down here?
Yeah, so let me start with in 2024, we're still in a pretty severe overdose crisis here in Clark County. So 802 lives lost in 2024 alone. And so we've actually seen a 103% increase in the age-adjusted death rate from 2018 to 2024, which is actually quite high. And so methamphetamine stands out. So we in 2024 alone, we saw 455 deaths due to methamphetamine in 2024, 115% increase since 2018. So it's something that we're keeping an eye on. And then fentanyl also stands out. So 454 lives lost due to fentanyl in 2024, which is 57% of all overdoses in 2024. But get this, that's more than a 700% increase since 2018 in the age-adjusted death rate. So it's
an
skyrocketed.
epidemic, yes.
Yeah.
Yeah. So it sounds like things have gotten pretty serious. And that's what? Let's go back. You said 2018. So let's call it 5 years or so.
Yeah.
Does that sound
5, 6
fair?
years.
I'm hearing that methamphetamine and fentanyl, let's call it opioids. Yeah. Are you okay if we sort of
Opioids,
refer to
synthetic opioids.
synthetic opioids. Yeah. These.
Pill
But,
can
you know,
kill.
oftentimes, like, I think fentanyl is sort of the synthetic opioid of choice now for
Yes.
various reasons. But we're seeing other substances as well, and we'll get to that. But it could be, you know, carfentanil, whatever, coming up into the future, unfortunately. Is there anything that makes Southern Nevada unique compared to other regions in this regard?
Yeah, so when we look at other regions, typically the primary driver is fentanyl, these synthetic opioids. But here in Southern Nevada, we have methamphetamine, which it has the same death rate as our synthetic opioids, our fentanyl. And so they both each make up of 57% of all overdoses each, just because more than one substance can contribute to a death.
Yeah.
And so that's it's pretty unique in Clark County when you have both methamphetamine and fentanyl contributing to the same death rate. And so it's that polysubstance use, that intersection of methamphetamine and fentanyl that really puts us in a unique position and separates us from the rest of the United States.
Yeah, and we see that actually in practice, this shift from let's call it single substance use or exposure. Historically, when I would treat patients who had an opioid use disorder or a stimulant use disorder, it was separate. It was full on separate. And now we're I call it sort of ubiquitous. So much so that if someone comes in and they're reporting that they're using methamphetamine or stimulants, or if someone is reporting that they're only using opioids, heroin, fentanyl, whatever it may be, I ask if it's okay if we do sort of a verification, a test, because invariably, unbeknownst to known or unbeknownst to them, there's exposure to both substances intertwined.
Yes.
And that's what you all are saying.
Yes.
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 Super unfortunate in the world of opioids. That for me is unfortunate because we have really good medications to treat opioid use disorder.
Yes.
And to date, unfortunately, we don't have a single FDA approved medication for stimulants or methamphetamine use disorder. Yeah, so that can be a huge challenge. What do you think it is about Southern Nevada that makes it that? Like, do you have any idea why we're seeing that it's not in other regions?
Historically, we have been a methamphetamine county here in Clark County. So we've always had higher rates historically of methamphetamine compared to the U.S. And so that's one thing. And then, here in Clark County, we have always followed the waves of the drug overdose epidemic as seen at the national level. But we tend to see those waves 2 to 3 years after the fact that they're introduced on the East Coast. So for those of you who don't know, there's been about 4 prominent waves over the past 3 decades. So the first one is the prescription opioid wave, occurring in 1999 to about 2010. And then from 2010 to 2015, the heroin wave. And then from 2015 to 2020, the synthetic opioid or the fentanyl wave. And then from 2020 to today is the stimulant with or without fentanyl wave. And so we have followed those waves, albeit a couple years behind when they're introduced on the East Coast. And then also we've had higher methamphetamine rates compared to the U.S. And then lastly, we've had just the polysubstance use of fentanyl and methamphetamine really just coming together and creating a very deadly situation here in Clark County. So those are kind of the 3 takeaways that Clark County is currently in that kind of separates us from the rest of the U.S.
If I could add to that a little bit, I want to say I think perhaps there are some cultural implications related to Las Vegas and what it means to kind of be in community here. I think that there are some other implications related to being on the West Coast. There's a lot more methamphetamine use historically on the West Coast than on the East Coast. So I think that's a contributing factor. And then one other piece, and Brandon, you may be able to talk a little bit more about this, is the heat of the desert and how that intersects with folks who are using stimulants and or fentanyl and what the implications of that might be, particularly for overdose death.
Yeah, so I recently did an analysis to look exactly at how extreme heat affects overdose.
Great,
And so through my analysis, I was able to determine that for every 1 degree over the max temperature for the day, for taking the average for the day, that it increases the risk for overdose 0.5%. So that may not seem like a lot, but if we have a heat wave, 10 degrees, 20 degrees, that's a 10% increase. And so we are really trying to push that extreme heat is a risk factor for overdose.
That's fascinating.
And that was using a Poisson regression.
Oh, okay.
I would like to say when I was using, I know that in the summer, my usage would go down just a little bit, especially when you're outdoors, because you feel woozy, you feel sick. I've passed out before. So I could definitely see what you mean about the overdose, being passing away because of just extreme heat.
And then if we were to log stimulant overdoses going from January to all the way to December, you would see that the peak in June, July, August, just that kind of like wave, that curve occurs. So that is something that we see on an annual basis. And so that's what initially kind of brought me where it's like, I really do think this is related. And so after running the data, it was, yep, this extreme heat and overdose is related.
Gotta love data,
Yeah,
man.
you gotta,
Numbers don't lie.
Yeah, you really do. And conceptually, it absolutely makes sense
Yeah.
from a physiological standpoint. I mean, on my best day when it's hot, I don't do very well. And as I'm getting older, my reserve for being able to tolerate. When I first moved to Las Vegas, I used to be out July peak heat, working in the yard. Wasn't a problem. And nowadays, I'm reaching for salt tabs, making sure I'm hydrated. So naturally, yes, it's. But what a cool sort of perspective, because I don't know in our efforts if we sort of have let the public know that.
Yeah.
We do talk a little bit about other sorts of things, like if you've had a period of sobriety or abstinence. Don't go back to what you used to use because it could be a bad situation.
much,
You could AKA overdose, right? But nothing along the lines of this sort of summer's coming, be careful, even more so.
So we're working to push out a kind of a public health bulletin kind of containing these data. And so once we do this, I feel like we will really be pressing the message that extreme heat is a risk factor. Be careful, post it in all the cooling centers that we have in Clark County and Las Vegas, and just make people aware, just because while, anecdotally we may think that, oh yeah, that's obvious. This is really kind of the first time we've kind of put, the data into action and kind of letting everybody know that this is the case.
This is true. It's
And
real.
we did an effort this year to reach out to all of the cooling centers in Clark County, just making them, before Brandon had done this excellent analysis, we're like, we just want to make you aware there's this association. And would you be open to training your staff on something like naloxone? And would you be able to make it available to patrons who are there as an opportunity for overdose risk? And good news, many of the cooling centers are libraries, and libraries have been an excellent partner in so much of this. But I do think finding those opportunities for continued partnership, using this data to really help drive these actions is an example of how we can save lives.
Yeah, directly.
Yes, directly.
Yeah, directly. So impactful. So, Brandon, you had mentioned some stuff comparing Nevada nationally, but maybe give us like this overall. How does Nevada trends, or how do Nevada trends compare to national averages across the board, across whatever you think might sort of separate us out or are good comparisons?
Sure. So we have higher rates of prescription opioids, lower rates of fentanyl, higher rates of heroin, lower rates of cocaine, higher rates of methamphetamine, and then also higher rates of benzodiazepine deaths. So so compared to the rest of the U.S., so that's kind of where we face. So lower fentanyl rates, and then lower cocaine, especially cocaine. So it just seems like our cocaine use is totally taking using methamphetamine. It just kind of absorbs that cocaine use. So all of our stimulants seem to be just focused on methamphetamine.
Yeah, and with that, because I mean, this is all fascinating, right? Substance use in America, across the world, but in America, these trends is really fascinating, because then it lets folks like you all, Jessica, sort of navigate, hey, what are we going to do that's specific to our region? Because we're seeing higher X and Y. And so for our, viewers, listeners, this is why this stuff is important.
Yes.
I don't know. An analogy would be like having a whole bunch of firefighters in Alaska for brush fires. I don't know if I'm even getting this right, because California has a lot of wildfires, right?
Yeah.
Well, maybe that's not the issue in Alaska. So these national sort of, What about substances? What are you all looking at? What are they looking at the national level? Are there new substances?
Yes.
So I've heard you mention fentanyl, of course, and that's sort of this new wave of synthetic opioids coming up, methamphetamine, but we've known about those. What about some new substances?
So some novel substances that are occurring at the national level, xylazines. So
Is that the horse tranquilizer?
yeah, so it's a veterinary tranquilizer. Medotomidine, which is also a tranquilizer of sorts.
Okay.
We tend to find those. So we have seen some xylazine overdoses here in Southern Nevada, but only used with fentanyl. So that it's not never used. We don't see any fatal overdoses of xylazine alone. It's only with fentanyl overdoses that we see xylazine. We haven't seen any cases of medetomidine, so I can search through that through death certificate data, so I can actually query the specific terms. Haven't seen any of that. And then carfentanil is a very potent type of fentanyl, so it's a very potent analog of fentanyl. So there have been cases, like some jurisdictions throughout the East Coast have really struggled with this. Here in Southern Nevada, we've had just a handful of cases over the past couple of years, nothing to get too concerned about. So with some of these new novel substances, we haven't really seen it rise to the occasion where it's kind of become kind of like our counterparts on the East Coast, where it's really grown and risen to a problem, that needs to be put out, like a fire that needs to be put out. We've just seen a handful of cases here.
Yeah.
I have
Go ahead.
I wanted to ask about, now I know there's Narcan for your opiates, but is there anything to counteract the xylazine or the tranquilizers or anything?
So-
is that why we're seeing the deaths?
So with xylazine and medetomidine, typically they are used with fentanyl. So if somebody is overdosing, we just want people to use naloxone or brand name Narcan, on that individual, just because there could be an opioid within that person.
Gotcha.
Yeah. So if somebody is overdosing, even on, if somebody typically uses a stimulant, if they report, no, I'm just using methamphetamine, we've seen so many drugs in Southern Nevada being cut with fentanyl that if somebody's overdosing, we want somebody to be putting naloxone in that person's system.
Gotcha.
And so any type of overdose, we want naloxone being used, even if that person states, no, or I just used meth, or their friend states, no, they were just using cocaine or methamphetamine. You just never know within our drug supply.
Okay. And did you say it works with xylazine, the naloxone?
It does not. But typically, xylazine is used with fentanyl, and so
I got you.
when naloxone is used
Makes
on
sense.
fentanyl, it takes it. The naloxone binds to the mu receptors, which then has a higher competitiveness to the fentanyl to the brain, and so it makes that person, live another day.
That makes sense. Thank
But
you.
this is a common myth, because when I hear about this discussed in the media, they say that xylazine or medetomidine is naloxone resistant, and that's not true. It's just not an opioid. And naloxone only works on opioids in the brain.
you.
So to Brandon's point, in that moment, as a responder to someone as an overdose, we're not asking you to make a determination about what they might have took. We're asking you to use the training that you have to look for the signs of an overdose, and then respond in turn with what you've been trained in, and leave the rest up to the medical professionals that are
Yes.
hopefully on their way, right?
Yes.
That are on their way to help you form that response.
And
makes
Jessica,
sense.
is naloxone hard to obtain here in Southern Nevada?
I mean, that's a great question. We're hoping no. We've the health district with many partners has been really working to make sure that that naloxone is a low barrier, easy to access for folks who need it to respond to an overdose. So many types of programs that we have around that.
I love it. And Empowered is a naloxone distribution
Yes.
site.
Yes.
Yeah, I mean, I would directly attest to that, because if you're able to get it because you know where to go,
Yes.
then absolutely. So not only is Empowered a naloxone distribution site, High Risk Pregnancy Center
Yes.
is one. It's pretty ubiquitous at the major treatment centers. Yeah.
Could somebody walk into the health district
Yes.
and request that?
Yep. Go to our pharmacy, and then they can get it for free. So no
awesome.
questions asked. They just, I want naloxone, and then they're given 1 to 2 doses for free.
Wow.
And admittedly, across the state, across the nation, but specifically Nevada has efforts to basically get naloxone, Narcan,
Yes.
the
Yeah.
brand name,
Yes.
naloxone into everyone's hands.
Love it.
Right? I mean, we've had discussions about this kind of stuff, like, wherever there's a defibrillator, whether it's
Yes.
at T-Mobile or a
Makes
concert
sense.
venue
Yes.
or
Exactly.
schools,
Yes.
just wherever that's available, we kind of got to be looking at making these things available, because overdose, when you look at 10-year-olds to 50-year-olds, is
Yep.
the number one cause
of
it's not a heart attack.
Yeah.
When we have these defibrillators, it's overdose. So, from a public health perspective, critical.
Yeah,
That is so
absolutely. I
smart.
think about it like a fire extinguisher.
Yes.
You don't keep a fire extinguisher in your house because you're planning your house to catch on fire. But
It's
gosh, are
just
you
in
grateful
case.
that you have a fire extinguisher if your
Yes.
house catches on fire? And so
Yes.
really the opportunity to access naloxone, like we've been trying to identify as many ways as possible. So we have a map on our website of every location that folks can pick up naloxone at
For free.
for no charge, right? So this is no
Yes.
charge naloxone. We work with several different agencies for kiosks and vending machines where folks can also pick up naloxone. So that's been excellent news. We're piloting one right now with our Clark County Library partners for 24/7 access to see what that's going to look like overnight. And then soon we'll be also adding naloxone access to our mail-based fentanyl and xylazine test strip program that we lovingly call the strip club.
Yes,
So we invite
have those
folks.
in office
have
too.
those
So we invite
Yes.
folks to join that club, and soon they'll be able to also opt in if they'd like to receive naloxone via mail. So we're really looking to explore, at least in Clark County, our partners at Impact Exchange have a program where they mail naloxone through the rest of the state. So really, we're trying to continue to identify where those opportunities are for engagement and access because we know how critical that is for overdose prevention.
I love
And
it.
just to add that when we kind of report these things to our grantors, that we are kind of pioneers in this, that we are kind of leading the way when it comes to a
Yes.
lot of these initiatives. So Southern Nevada has a really strong point when it comes to distributing these medications like naloxone and fentanyl and xylazine test strips. And so we have a lot to be proud of when it comes to that.
Yes.
I did want to circle back on something that you talked about related to novel substances. So I think Brandon showcased a really important opportunity where we look at mortality statistics. That used to be all that we had. So we had to wait for people to die to be able to know what substances of concern were. And with our overdose data to action local funding at the health district, we had an opportunity to do some novel surveillance through a drug checking program that we've been implementing with the National Institute for Standards and Technology, NIST, out of the Department of Commerce. So we sample what I would consider to be someone's trash, so used items from folks in community, whether that be on outreach or through our partners at Impact Exchange in the center. And we send the swabs for that to NIST, and they do an analysis for us. So that's allowed us to really stay boots on the ground of what's happening in our community. And the data related to that is reported on our dashboard, which we're really proud of. We're excited about that. And it's helped us monitor for these novel adulterants. So Brandon mentioned xylazine. We had our first indicators that xylazine was here in our drug supply through this drug checking effort. And the health district was able to issue a press release and have conversations with folks in community talking about exactly what you were saying, Amani. So the overdoses may be looking different if your friend or your colleague is experiencing an overdose might look different than before. And when you administer naloxone, that response might look different than
Yes.
before. So, and this is why, because what we're seeing is xylazine in the drug supply. It's also allowing us to monitor, as Brandon mentioned, we've seen a trend where things sort of begin on the East Coast to a certain extent. We keep an eye on that to see if and when it comes to Nevada. So it's allowing us in real time right now to monitor for things like medetomidine and nitazines, things that have caused overdoses for our friends and colleagues and out on the East Coast and now into the Midwest. We're keeping an eye on that here in Nevada so we can take the same proactive approach.
Yes.
So we don't have to wait for the
Exactly.
autopsy
Yes.
reports.
The autopsy
Yes.
And our coroner's office is often underfunded to be able to do these additional complex analyses to test for everything. So
Yep.
really, we're proud of this surveillance initiative and communication about this data as a way to really help folks boots on the ground save lives.
And
I
I
love
will
it.
say, so part of our NIST program, NIST was able to detect xylazine before wastewater was able to detect
wow.
it.
Yeah,
So
wow.
just really on the front end, like as soon as possible, we were able to see it. And then months later, we were able to detect it in wastewater. So just how valuable a program, like,
Yes.
sending these swabs over to NIST to analyze is for jurisdictions.
Yeah, I mean,
is so cool.
in that respect, I think we're fortunate, that we're sort of 2 to 3 years behind national
Yeah,
averages because it gives us time to, right, prepare.
Yeah.
Yeah.
Along those lines, prepare. One of the biggest bummers for me with substances nowadays is this notion of moving towards synthetic
Yes.
substances. All these, I mean, your body is really complicated. As it stands now, I'm going to say currently very challenging, if not close to impossible, to test for any substance that someone can concoct in a lab somewhere. So this is why this stuff is really important.
Absolutely.
I don't have a set of tests that test for 100,000 different substances, and to say, oh no, this person has megablastamine on board, and here's the antidote. You know what I mean? So super important.
And like what I was saying, like these waves of drug overdoses just seem to change every 5 years, and so we always have to pivot and look towards the next thing, and then invest in prevention to try to mitigate these deaths.
I have a question, just really quick. A novel drug is a designer drug.
Great
I'm
question.
sorry,
So,
I'm
like,
lost.
so terminology. In general, I think designer drug more so has this. What is a classic one? Maybe something like ecstasy, MDMA.
Okay.
Designer,
Gotcha.
cocaine. Oh, it's fancy. Versus when we say synthetic, it really just means someone's making it.
Got you, like your meth.
Correct.
Got you.
Versus something classic like heroin, we don't call synthetic because heroin, the base, much like a lot of our opioid medications, it starts from a poppy, something that has to be grown, that gets turned into opium, blah, 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 da, 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 da. But something like methamphetamine or fentanyl, you don't need that. You just do some stuff in a lab, which is why we're seeing those things. It's hard to grow poppy.
Yes, it is.
Yeah.
It's
Or
hard.
cocoa or the cocaine.
It's cheaper.
Exactly. I mean, the bang for your buck on these synthetics is massive,
Makes
right?
sense.
They're more potent. 4 grains goes a long way compared to 4 pounds, of the older stuff. But it is a huge bummer. And so it does mean that the work that you guys are doing, I don't see an end to.
Yes.
Yeah.
No.
I see it as continuum as long as I'm here on this planet.
Yeah.
And the danger is nobody knows what's in the drug supply. And so people who buy substances don't know what they are taking as well. So we routinely see fentanyl cut in with multiple substances. People think they're just buying methamphetamine when in fact it's meth and fentanyl and other things. And so that's what makes it so dangerous. And that's why, like you said, this work is never ending, and we will just continue to
Never-ending.
just make sure people have the tools that they need, that they can save their own life or other people's lives.
I didn't know, but when I had started working at Empowered, we have all you guys as testing strips and whatnot. And so there was a fentanyl one, and I was like, oh, why would, because I was blind to why are we doing this? We just want to stop. And they were like, well, it's for you to test your, if you're doing a drug besides fentanyl to see if there's fentanyl in it. And they didn't just leave it like that. They were like, but also it's for you to test your fentanyl to make sure you're just taking fentanyl, what you want. I'm like, is that crazy out there? Lord got me out real quick.
Yeah, it really is. Along those lines, something that I want to sort of pivot to is this notion that we always say this, is that substance use disorder, substance use, addictions doesn't discriminate. It'll welcome all comers.
Yes.
I don't care what race,
No,
what
it's
gender,
the
what
social
socioeconomic
step,
status, where you live, really, it doesn't matter.
Yes.
But there is this notion that certain demographics are disproportionately affected. Can you guys talk about that? What do you see?
Sure. So I can say that African Americans have the highest overdose death rates in Clark County across several categories. So fentanyl, all overdoses, all opioid-related overdoses, and methamphetamine, unfortunately. And we see that kind of ebb and flow across the years, but in 2024, that is the case. Now, whites and Caucasians typically have the highest frequency of deaths, but the highest rates due to African Americans having a smaller denominator, a smaller population. That's what really kind of sets it apart. And so when we look at social vulnerability, we tend to utilize, luckily the CDC has an index that we can use called the Social Vulnerability Index, which is amazing. So
Very
they've
cool.
compiled data that takes in housing status, ethnic minority status, if they have insurance or not, access to transportation, and so many other variables, and they lump it into one statistic. So the higher it is to one, the higher the social vulnerability they have. And so this is done by census tract. And so we like to take that, display those data, and then overlay our overdose death data and see which census tracts stand out. And so we can really hone in on the specific areas of Las Vegas that have this high social vulnerability, high overdose issue. And so typically the areas with high social vulnerability do tend to have higher overdose rates as well. And so that's one takeaway. But that's there's other indices that we can use. Another one that takes in more external environmental factors, like the environment, the pollution level and also heat. And so we tend to use a lot of these indices to tailor, at least for some of our programming, to who to specifically target, which is very interesting.
Sure. Yeah. I mean, I love this notion. I mean, you guys are ahead of so many things.
Yes, yes.
Because with the work that we do, and let's just call it healthcare in general, we are trying to include those social determinants, right, of health, SDOHs. At the new med school that we have at Roseman, we are absolutely integrating that into our curriculum because it does affect health and wellness and well-being. Specifically here, we're hearing that it absolutely does. We see it, right? But let's call that anecdotally, right? Yeah. Anecdotally, but that the data does support. Can you give us just some of those things? You mentioned some, but just clear, what is it that sort of leads to those higher indices or part of those social determinants that do directly affect higher or lead to higher rates of overdose?
So, income level, so racial and ethnic status.
Okay.
Access to insurance. The number of individuals in your household. Transportation access, if you have transportation or not.
That makes
sense.
So
those are some that come to my mind. There's 6 or 7 more that I'm missing. But
Brandon, the
Yes.
reality is those are classic. Those are classic. What
yeah.
we expect, what we see, what our patients report, all those kinds of things. So that's why there is a lot of focus on addressing. Outside of me writing a prescription, right? I can write the most perfect prescription ever. But if someone doesn't have transportation, access to insurance, you name it, food, housing,
And so when I display these data, the social vulnerability data, you can see it kind of just fan from the middle all the way outwards to the valley. And then the same with overdose deaths. You see it concentrated in the middle, fan outwards. So there seems to be an association there, just obviously that higher social vulnerability yields higher overdose
deaths. Yeah. Really unfortunate because it's very challenging.
It is.
It's very challenging to, I can have a lot of general sort of campaigns. Hey, we should be screening and hey, we have these medications and therapies and all this stuff that works for treatment. But I don't know what to do for someone who's experiencing homelessness, housing insecurity, food insecurity. I mean, programs like Empowered, programs that you guys have, absolutely. But me on an individual basis, I want to sort of get to the same vein because, we oftentimes talk about the perinatal reproductive age population. So those folks that can become pregnant, are pregnant, or are now postpartum or will be postpartum. What do substance use trends look like for them?
So I have some data hot off the press.
We need that.
Fresh data to share. So between 2018 and 2024, 602 women of childbearing age, 15 to 44 years, died from overdose, with 2024 reaching a record high of 100 deaths. So a 39% increase since 2018. So that's an unfortunate statistic to share.
Absolutely.
Fentanyl is the primary driver, with deaths among reproductive age women increasing 560% from 10 in 2018 to 66 in 2024. So fentanyl now accounts for 2/3 of all overdoses in this population. Psychostimulants like methamphetamine, those deaths rose sharply, reaching 55 deaths in 2024, 57% increase in 2018 since 2018. And then overall, opioids were involved in nearly 3/4, about 74% of deaths, while heroin has been nearly displaced, falling 62% from 2018 to 2024, as fentanyl dominates our drug supply.
It does.
absolutely.
It does.
Yeah.
Absolutely.
Yeah, I know. Some sobering statistics.
totally
not,
sobering.
Not, probably uncommon to hear or unfamiliar to
Correct.
hear.
Yeah. Speaking from a maternal mortality perspective, yeah, we see that. Right. We see that. And I don't know that necessarily Nevada separates from national trends on that regard. Number one cause of pregnancy associated overdose. And I think we see that across the nation, which is sort of a testament to how awful these things are, but also on the positive side, at least, how well we are doing from a healthcare perspective at the classic causes of maternal mortality, things like bleeding, infection, you know, these complications from pregnancy, of which substance use is not a classic.
Yeah.
It's becoming, unfortunately, but okay. I would now. I sort of we're getting to the end here, and I want to hear a lot from Jessica.
Yes.
her bread and butter. Okay, so Brandon, you have amazing data. You basically know what is going on. Cool. Now, Jessica, knowing that, what does, let's say Southern Nevada Health District, but what are you guys doing? How is this data shaping what you're doing? What does intervention look like? What does prevention look like? Have at it. Go for it.
I love this. So thanks, Brandon, for really, I think it's that framework and that lens that we utilize to really identify all of our interventions. We have a data to action framework that we utilize. So I want to talk a little bit about that because I think it's an important and a feedback loop for us to make sure that we're on the right track and using both our dollars and our programming effectively so that we can continue to really focus in on folks who need services the most and where the biggest gaps are. So we started what we call our data to action meeting. Brandon chairs it, and he shares these data and more with our team internally. So these are folks who are doing boots on the ground outreach, who are in our jails doing screening and intervention for folks syndemically around HIV and substance use. These are folks like myself and my health education team who are listening and identifying and trying to suss out some of these patterns and details that Brandon is sharing. We include our drug checking data in this, and we include some programmatic data as well. So for folks who report using naloxone, we have a little bit of that data from our outreach teams. For example, what does that look like and how is that informing our efforts? And Brandon's also brings in narratives that I think are so powerful. So we talk about these things kind of at the population level, but what are some examples of how that's played out? What are these stories from real people? And we do this meeting once a month, which has been incredible. We also update our data dashboard once a month, so it is timely. I know, right?
Great.
So what I think has been powerful is it allows this dialogue. It allows our boots on the ground folks to ask questions and get clarification about the data. Oh, so what does this mean? Are you saying this? Are you not saying this? And give us those talking points. So things that we're proud of that have come out of this type of framework and meeting. The conversations that our teams on outreach are having are always about methamphetamine and fentanyl together in our drug supply. And what are you interested in engaging in treatment and care today? And if not, what supplies, tools, or things can we offer you for you to stay safe today? And where's your off ramp, like if and when you're ready and when you need it. So really meeting people where they're at, but not leaving them there, right?
Love it.
We've identified partners throughout the valley, the Regional Transit Center, as a key opportunity for, hey, are you guys interested in naloxone training? You're working with folks across the board. We know transportation is a barrier. We know a lot of folks are on public transit. Can we help? And they were like, of course, come train our staff. So identifying these sort of community and systems level opportunities where we can bring in health education as really that place to start for engagement. So that framework has been incredible. And we start every meeting with, what changed from last month? Did we make any progress on any of these action items we identified from last month so we can keep that feedback loop going? It's a key evaluation metric for us as the impact of this program. And I share that with you because our office and our program in general has been data to action from the jump, right? Like we are using this to inform. The change here is that we are having this in an ongoing, timely conversation because we know the drug supply is changing and it's often changing rapidly.
Yes.
So we also need to be able to adapt. What are the new test strips that need to go out? Like where are the new places where folks need education in naloxone? So we've been really proud of that and proud of that feedback loop. And it's something that we've been able to present on at national meetings of how we've structured this and what that communication looks like, how we're protective of the information we need to be protective of, and how we then communicate those high-level findings with our partners to help direct programming. So I think that's been essential. I want to kind of share about two key opportunities that the health district does. But look, we don't do this alone. We can't. It would be irresponsible for us to do this alone. We have so many incredible partners that we either work with in a networking capacity, a coordination capacity, and a grantor capacity. And I think we've been really lucky to come to the table with so many incredible people through things like the Southern Nevada Opioid Advisory Council, the SNOAC, which is a coalition group of folks just looking to do innovative work and identify where these cross sections are in our community. Some of the projects the health district has underway, we have like 5 linkage to action programs. So I would consider Roseman being one of them, right?
Yes.
With that incredible peer support. We have folks in Clark County Detention Center who are doing linkage to care. We have some peers in the rural drug courts in Mesquite and Boulder City, right?
Awesome.
So they're connecting folks up who are coming out of drug court and building recovery communities in some of our more rural parts of Clark County. We're so proud to be able to engage our folks who are in more rural parts of our community. We often talk about the urban areas, but we know resources are needed everywhere, right? We have programs at the center, at Impact Exchange, which is our local syringe services program, that are linking folks in real time to these incredible services. And we have a peer program that we've been piloting at Valley Health System to engage and link folks in real time who are coming to the hospital for experiencing an overdose and identifying that they want some peer support and what that looks like. So the linkage piece, I think, is incredible.
Yes.
Peer navigation, lived experience, navigators in general. I can't say enough about building that bridge to care and how incredible that's been. And then we've been really proud to stand up some what I think are awesome overdose prevention supportive services. I got to talk earlier about our naloxone work. We're very proud of that. Brandon has been a leader at SNHD in making sure that happens. And I cannot tell you the amount of funding sources we braid together to be able to saturate the valley with naloxone. We also have a test strip program. So we distribute fentanyl and xylazine test strips just for the reasons you said, Amani, right? We meet people where they're at, but we don't leave them there. So we're offering that opportunity for overdose prevention and reduction of risk, right? From a fatal overdose. Gives folks another day and another opportunity for that engagement and care. We distribute those test strips via mail, and we have a map on our website with all the places folks can pick them up, no charge. And we'll train people. We train folks all across the valley on these strategies and the importance of overdose prevention and on stigma and how to reduce stigma for yourself, for your agency, across your work. And we've been rolling out these, I think, pretty amazing sort of intersections around health education. So we know substance use and gender-based violence have a large intersection, right? And so education around how folks address both of those and what that looks like. We take a syndemic approach with HIV and hepatitis C and substance use, such that when our disease investigators are going out in community, they can bring naloxone right to folks, just like your peer navigators can bring naloxone right to folks, right, in communities. So that's been kind of a foundational and core concept in the way that we've approached it and way that we've encouraged others to think about their work in community. I could probably go on for the rest of another 45 minutes to talk about all of this. I'm really proud of the work that we've been able to be a part of, been lucky to be a part of, and been able to do in community, not just ourselves, but together, really, in collaboration.
We're so blessed to have you guys out there, literally, like you said, boots on the ground, doing all this work, getting all this data, getting all this information and educating us. Not just, oh, we have this information, it's here, we know about it, but we're going to very little. You have to find and look for information. You guys are blatantly putting it out there on your webpage, and it's up to date. Because a lot of times you go on these websites and it's like from 2019. I'm like, it's like 6 years ago.
Yeah.
A lot can happen, you know.
As Brandon said, a lot's happened in 6 years.
A lot has happened.
So thank you so much, both of you guys and everybody that, you know, is a part of this, especially for women like me, you know. Knowing and educating yourself and knowing what's out there. I really had no clue about the xylazine. Honestly, I heard about it real quick and never heard really too much about it. Wasn't really educated on it, you know. So we really appreciate you guys really out there giving back to people who really need help, honestly.
Yeah, thank you to Jessica and Brandon for joining us today on Empowered Voices for this very insightful discussion.
Yes.
I mean, let's call it priceless. Yeah, let's call it priceless. Oftentimes when we're talking about these huge sort of initiatives at the state level or regional levels, there's this notion that we should be accountable for effectively the people's money. Yeah, the people's money that gets used.
Yep.
And so the fact that legislators have identified this, our state authorities, you all are doing the work. Every dollar that goes in is basically paying us out infinite. It's hard to do. It's hard to put an actual value.
Yes.
Just to put things into perspective, back in 2020, there was a legislative report that came out, right? I think it was from a congressional report, and that was 2020. It wasn't even peak. That the economic impact in 1 year for the opioid epidemic only, we're not talking about methamphetamine and other substances, opioid only was $1.5 trillion. That's a lot of money.
You pick my mouth up off the
Exactly. So thank you for everything that you do. It is absolutely priceless, and it impacts so many. It impacts everyone. It impacts everyone in one way or another, much in the same way that we see substance use impacting someone, whether it's 2 degrees over here, it was a friend, it was a family member, a significant other, someone you knew. We see it happening. So, yeah. What else do I want to say? Keep up the good work.
Yes.
Likewise.
We're proud of you, man.
We're proud of you all.
Keep going for our viewers, our listeners. I'll close with this and then I'll do the rest, is that if this was not happening, let's look at the other end. If it was not happening, I would bet every single last dollar I am worth that there would be more deaths.
Yes.
Point blank.
Oh, yes.
Yeah, for sure, right? There's like
Yes.
not even a question.
No.
So there you go.
Yeah, we keep track of the outcome of the naloxone administration for those who fill out a survey, and it's, you know, to the hundreds and hundreds. You know, we see when we review these data on a monthly basis, we can see 500, 600 lives saved due to the naloxone that we distribute.
Yeah.
And that's just what we know about.
That's just what we. Yeah.
There it is.
I just want to say, we don't do this alone. We do this in community, and that's what makes me proud. That's what makes me proud to live here and work here and get to do this work. We do it in partnership.
Yeah.
We love that. One more time before we leave, I wanted to ask, can you please, for our viewers that are listening, the easiest form to get naloxone? What would be the easiest way?
I think to go on our substance use dashboard, and you can search for any site that's on our dashboard, and then go to that site and get it for free. Or you can email od@snhd.org.
od@snhd.org. Perfect.
Okay. Thank you for listening or watching this episode of Empowered Voices. Be sure to subscribe wherever you get your podcasts, as another episode drops in 2 weeks. Also, don't forget to rate and share with others who may find our information discussion topics helpful. We encourage you to visit our website, empoweredmoms.org, to share your thoughts on this episode or suggest topics. you'd like to hear more about in future episodes.
Yes.
Thank you both.
Thank you for having us.
Thank you for coming. If you live in Southern Nevada or in Reno, Carson City, Churchill County, or Lyon County in Northern Nevada, or in Weber County or Davis County in Utah, and you're pregnant or recently had a baby and using opioids or stimulants for any reason, there is non-judgmental help available to you. No referral or insurance required. Visit empoweredmoms.org for information or to request services. If you live outside of these areas, we encourage you to find resources in your community.
Empowered Voices is a podcast production of the Empowered program at Roseman University College of Medicine, supported by the Centers for Disease Control and Prevention's Overdose Data to Action grant through the Southern Nevada Health District. This project has been funded by grant number NH28CE003534 from the Centers for Disease Control and Prevention. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by the Southern Nevada Health District, CDC, or the U.S. government. Hosted by myself, Dr. Farzad Kamyar, and Amani Wilson. Executive producers are Dr. Andrea Peterson and Jason Raw, with production assistance by Rachel Mack. Recorded at the Video Podcast Studio in Las Vegas, Nevada. For information about this podcast and past and future episodes, visit empoweredmoms.org.